Hi, good morning, everyone. It is 11 o'clock, and we're going to give folks a couple more minutes to join. Okay, fantastic. I think most folks have already joined us, and I don't want people to wait much longer. So, welcome. Good morning. As a preferred revenue cycle vendor for Arizona HHA, HRG is pleased to offer today's Lunch and Learn on the topic of telehealth services and COVID-19 vaccines. My name is Megan Smith. I am the Executive Director of Quality and Training at HRG. I have over 19 years of revenue cycle experience, really in all facets of patient financial services. And in my current role, I work with an amazing team developing and presenting company-wide training in addition to oversight of HRG's quality audit program for both billing and HIM departments. With me today, I've got Kelly Ryan, who is our Regional VP of Business Development, and Nikki Silva, who is the Director of Internal Coding Audits, Training, and Education. So just a couple of housekeeping items as we go through our presentation. I will have everyone on mute, but feel free to use the chat button if you have any questions. Looking at our timing here and in our presentation, I'm thinking we will have some time at the end to answer some questions from the audience, and then we will always follow up in addition to sending out information for the slides and the recording, because this session is recorded. We'll also follow up with some of the Q&A that came out of our time today. Okay, so let's go ahead and get started. So we've got three main things that we're going to be talking about today. Telehealth expansion. So I'm not going to talk too much into some of the changes and things that happened as a result of the public health emergency, but we are going to touch on what's staying as a result of that, and then really what's going and what does that mean? What is the impact of the PHE expiration in terms of providers and the services that can be provided over telehealth? And then we're going to do kind of a deeper dive into COVID-19 vaccines. We're going to talk about billing. We're going to talk about some of the CDC recommendations, the vaccines themselves. So we're going to spend a lot of time today talking about vaccines, which I think is really timely because although we're a couple of months in, it's still really fresh to a lot of providers across the United States on how to handle those. So jumping first into telehealth, before the COVID-19 public health emergency, only about 15,000 fee-for-service beneficiaries were seen each week through telemedicine services. And when I say beneficiaries, I'm talking Medicare. Since the beginning of the PHE, CMS has added 144 telehealth services, such as emergency department visits, initial inpatient and nursing facility visits, and discharge day management services that are covered by Medicare through the end of the PHE. These services were added to allow for safe access to important healthcare services during the PHE. And as a result, preliminary data showed that between mid-March and mid-October 2020, over 24.5 million out of 63 million beneficiaries and enrollees have received a Medicare telemedicine service during the PHE, which is a huge spike. This final rule, delivered as an executive order, focused on improving rural health and telehealth access by adding more than 60 services to the Medicare telehealth list that will continue to be covered beyond the end of the PHE. And CMS will continue to gather more data and evaluate whether more services should be added in the future. These additions allow beneficiaries in rural areas who are in a medical facility, like a nursing home, to continue to have access to telehealth services, such as certain types of emergency department visits, therapy services, and critical care services. So published on December 1st of last year, CMS's calendar year 2021 physician fee schedule final rule expands coverage of Medicare telehealth services in several ways. The regulation finalizes policy, which will result in Medicare covering 251 types of telehealth services as of January 1st of this year. These services fall into three groups based on when Medicare coverage of these services is due to expire. Additionally, CMS also announced a commissioned study of its telehealth flexibilities provided during the COVID PHE. The study will explore new opportunities for services where telehealth and virtual care supervision and remote monitoring can be used to more effectively bring care to patients and to enhance program integrity, whether they are being treated in the hospital or at home. So let's dig into each of these three groups. CMS added several services permanently to its Medicare telehealth service list, which is shown here as Group A. This group represents about 45% of the telehealth services that will be covered by CMS as of January 1st of this year, and includes services such as group psychotherapy, neurobehavioral status exams, short home visits, and a visit complexity code, G2211, which is inherent to evaluation and management associated with medical services that are part of an ongoing care related to a patient's single, serious condition or a complex condition. Note that G2211 is an add-on code that should be listed separately in addition to the E&M and applies to both new or established patients. CMS classified these services as Category 1 under a streamlined review process based on their determination that these services are sufficiently similar to services already on the list of Medicare telehealth services. And for the home visit codes, the 99437 through 99438, the patient's home can serve as a qualifying originating site when the patient is being supported for a substance abuse disorder or a co-occurring mental health disorder, as permitted by the Support Act. Based on trending and 2021 estimates, the majority of Medicare telehealth volume is likely to occur with services in this group. CMS also finalized its proposal to allow all Category 3 telehealth services added to the Medicare telehealth list during the public health emergency for the COVID-19 pandemic to remain on the list through the calendar year in which the PHE ends, as represented here in Group B. This group represents 23% of all telehealth services covered on January 1st of this year and includes services such as emergency department visits, all levels of physical therapy, occupational therapy and speech pathology, hospital day discharge management, and critical care services, just to name a few. CMS's rationale for covering these services on a temporary basis is to gather data to assess if these services should be covered on a permanent basis starting in 2022. Under this last group, CMS will cover a large group of telehealth services only until the PHE expires, which as of the last extension effective January 21st, it is set to end on April 20th of this year. This last group represents 33% of all telehealth services covered on January 1st of this year and includes services such as audio-only telehealth visit codes, initial hospital and nursing home visits, and home visits for new patients. You can review the full list of temporary codes allowed during the PHE by visiting the 2021 Medicare Telehealth list of services and filtering the list for items described as temporary addition for the COVID-19 pandemic. CMS also finalized in its recent regulation coverage enhancements for other Medicare virtual care services, such as remote patient monitoring in patients' homes and quick clinical visits described as communications technology-based services, or CTBS. CMS's policy changes are expected to remove some of the barriers providers face in offering remote patient monitoring and communication technology-based services to their patients. For example, the remote patient monitoring service, CMS will permit patient consent to be obtained at the time of service delivery and will also permit auxiliary clinical personnel to provide RPM services. On an interim basis, which in this case means for the duration of 2021, CMS created HCPCS code G2252 for extended services delivered via synchronous communications technology, including audio only. These services are considered to be a communication technology-based service and is subject to all the other requirements of CTBS. G2252 is crosswalked to CPT code 99442 for reimbursement purposes, making its reimbursement higher than the current more limited duration virtual check-in code. The code is intended for situations when the acuity of a patient's problem is not necessarily likely to warrant an in-person visit, but when additional time is needed to make this assessment. Because it is a communication technology-based service, the traditional telehealth service location restrictions do not apply, which in part means G2252 can be used regardless of the patient's geographic location and regardless of whether the PHE ends prior to the end of calendar year 2021. Thus, while the audio-only telehealth codes currently approved, subject to Section 1135 of our PHE waivers, may only be used during the PHE, this code would extend beyond the PHE. The communication technology must be synchronous and is subject to the same billing requirements as other virtual check-in codes. And CMS is considering whether this interim policy should be adopted permanently. Until December 31st, 2021, or the end of the PHE, whichever is later, direct supervision can be provided using real-time interactive audio-video technology. The current definition of direct supervision requires the physician to be physically present in the office and immediately available to furnish assistance and direction throughout the performance of the procedure. Under the new definition, direct supervision can be met if the supervisor physician is immediately available to engage via interactive audio-video. This change does not require the physician's real-time presence or observation of the service via interactive audio-video technology throughout the performance of the procedure. And remember, audio-only technology is not sufficient to fulfill direct supervision requirements. The duration of this change is time limited because CMS has concerns that widespread direct supervision through virtual presence may not be safe for some clinical situations and overutilization could occur. CMS will study and collect data on whether this change may be appropriate on a permanent basis after the PHE expires. And lastly, CMS is reducing the frequency limitation for coverage of subsequent nursing facility care services furnished via telehealth from once every 30 days to once every 14 days. The original 30-day restriction was due to concerns on the acuity and complexity of nursing facility residents and to ensure nursing facility residents have frequent encounters with their admitting practitioner. CMS was persuaded that the use of telehealth is crucial to maintaining continuity of care in nursing facilities and to honor the independent medical judgment of treating clinicians to decide whether telehealth versus in-person care should be used, depending on the needs of each specific resident. Frequency limitations have already been temporarily waived for the duration of the PHE, but this new rule change is permanent, effective January 1st of this year. While Medicare Telehealth Service Group 3 will cease to be covered after the PHE expires, the expiration of the PHE will have other critical implementations for service groups 1 and 2. For services in groups 1 and 2, the expiration of the PHE will end the ability for providers and patients to conduct all of these services via audio-only communication from the patient's residence and from locations in urban areas. Telehealth will once again be limited to established patients. New patients must have at least one in-person visit with a provider before being eligible for telehealth. So why is this happening? These Medicare telehealth limitations are written into statute at Section 1834 of the Social Security Act, and CMS lacks the statutory authority to modify them. It was only through this waiver authority under Section 1135 of the Social Security Act that CMS could temporarily remove these limitations during the PHE. Therefore, removing these limitations to Medicare telehealth coverage requires Congress to pass legislation modifying Section 1834 of the Social Security Act. So now let's dive into vaccines. So first, let's talk about what emergency use authorization entails. So an emergency use authorization is a mechanism to facilitate the availability and use of medical countermeasures, including vaccines, during public health emergencies, such as our current COVID-19 pandemic. Under an emergency use authorization, the FDA may allow the use of unapproved medical products or unapproved uses of approved medical products in an emergency to diagnose, treat, or prevent serious or life-threatening diseases or conditions when certain statutory criteria have been met. This criteria includes that there are no adequate, approved, and available alternatives, and clinical trials have been conducted according to the rigorous standards set forth by the FDA. Taking into consideration input from the FDA, manufacturers will then decide whether and when to submit an emergency use authorization request to the FDA. So first on the list, we're going to take a look at our specific vaccines, and these names should look familiar. First on our list to be granted emergency use authorization is Pfizer, who received their EUA from the FDA back on December 11th of last year. 7 days later, on the 18th, Moderna received their emergency use authorization. Both Pfizer and Moderna currently require 2 doses, with the interval between doses set at 21 days and 28 days, respectively. In addition to the vaccine code, each has a unique administration code that differentiates between the first and second dose, so be sure to have your charge master updated. CMS has also provided NDCs for each vaccine. Last month, Janssen, or more widely known as Johnson & Johnson, received their emergency use authorization on February 27th. Unlike the last 2 we discussed, this is a single-dose vaccine, so there is no need to schedule a second appointment. And just like the other 2 EUA-approved vaccines, the Janssen vaccine has a unique administration code. Lastly, we have the AstraZeneca vaccine, which is another 2-dose vaccine and is currently not approved for use in the United States. Since the Moderna and Pfizer vaccines are administered with 2 doses, the CDC has provided guidance to increase provider success rate of fully vaccinating patients. The CDC advises both doses of the series should be completed with the same product, citing the safety and efficacy of a mixed product series has not been evaluated. A couple strategies you can use to ensure that patients receive the second dose with the appropriate product and interval between doses include making an appointment for the second dose before the vaccine recipient leaves to increase the likelihood that the patient will present at the same vaccination site for the second dose. Providing COVID-19 vaccine record cards to vaccine recipients, then asking recipients to bring their card to their appointment for the second dose. It's also a good idea to encourage recipients to make a backup copy, for example, taking a picture of the card with their phone. Encouraging vaccine recipients to enroll in a free smartphone-based tool such as vSafe, which uses text messaging and web surveys to provide personalized health check-ins as well as second dose reminders. The Vaccine Finder website helps people find information about providers who offer select COVID-19 vaccines. Vaccine Finder also allows healthcare providers to list their vaccine locations in a centralized, searchable database and to track vaccine availability. The Vaccine Finder serves 2 roles in the COVID-19 vaccine program: inventory reporting, which is required for all COVID-19 vaccine providers. Each day, providers report on-hand COVID-19 vaccine supply through the Vaccine Finder COVID Locating Health Provider portal. And the ability to share information about COVID-19 vaccinating locations. It is optional for vaccine providers to display their location to the public. COVID-19 vaccination providers that will be receiving vaccines may choose to make their location publicly visible on Vaccine Finder, making it easy for the public to find information about locations that carry COVID-19 vaccines and learn how to make an appointment. In terms of vaccine documentation, each recipient vaccine should be recorded in the patient's record within 24 hours of administration. Should include the vaccine date and, the vaccine and the date of administration, which vaccine, whether in terms of manufacturer, whether it's the Moderna, the Pfizer, or the Janssen, lot number, the site and route, name and title of the person that administered the vaccine. In addition, a vaccine record card given to the vaccine recipient should include the date, the product name, manufacturer, a lot number, name and location of the administering clinic or healthcare professional. In terms of diagnosis coding for the COVID-19 vaccine, there is only one ICD-10 code utilized for COVID-19 vaccines, and that is Z23, Encounter for Immunization. At times, a patient may present symptoms after receiving the vaccine, and the question of coding adverse effects has come up. Generally speaking, if a side effect is detrimental and pronounced, requiring medical attention, workup, or treatment, then it is an adverse effect. If determined the patient experienced an adverse effect, diagnosis coding would include the Z23 as primary with subsequent adverse effect diagnosis codes. Adverse effects can also be considered an adverse event. Serious adverse events result from medications or medical products with outcomes such as death, life-threatening reactions, hospitalization, disability, necessity for intervention to prevent permanent impairment or damage, or other serious outcomes. Adverse events are reported to the U.S. Food and Drug Administration. So now let's take a look at billing in terms of our vaccines, the three that are available and are being administered right now. Providers do have the option, and these providers listed on the slide here all have the option to either do roster billing, which is appropriate when you are vaccinating 5 or more patients in a day, or they could do single patient billing. So let's dig a little bit more into what roster billing is. So roster billing, in a nutshell, is sending over a listing to your MAC, to CMS, which is a listing of the patients that were vaccinated, in addition to claim forms that are attached. If you're billing Part B, you would attach those claim forms and it gets sent over in a packet. Vaccine administration should be billed, vaccine administration is billed and reimbursed separately from inpatient charges. So keep that in mind. If you have a Part A patient, you can bill the vaccine separately to Part B, and it can be done from a roster, or it can be done individually. Part A roster billing does include, like I mentioned, the roster in addition to individual claim information. But as Part A, since they do not accept paper claims, you're going to need to key that in to DDE. There are instructions on the CMS website at the end of this slide. I believe we do have that resource on there, and it's really good instructions that Noridian has put together. So your type of bill does depend on your facility type. So for example, a 12X is going to be your Part B charges on a hospital inpatient account, and a 34X is going to be for home health, for example. Your revenue code should be 771, and that's going to be for your administration of the vaccine. Physician, non-physician, pharmacy, and mass immunizers can bill using a 1500. You're going to do the place of service 60. The only exception is for your RHCs or your FQHCs, which we'll get into that in just a moment. For your Part B, you are able to send in paper claims, so there is a roster template depending on the MAC that you use. I know that Noridian has a really nice one out there. So check with your MAC and see who you would be submitting your claims to, and see if they have a roster template available. Most of them do. So it would be the same situation. You'd have your roster template listing all of your patients on there, and then you would attach the claims behind that. So let's look at what FQHCs should do. So you want to submit a claim to report your HCPCS for both your COVID-19 vaccine and the administration. We're looking at a type of bill 77X. Our revenue codes are 771 for your administration and 636 for your vaccine. So the HCPCS are going to be considered informational only, because your FQHCs are going to be reimbursed by way of the cost report, similar to the flu and the pneumococcal vaccine. For your RHCs, you're going to simply report this on your cost report like you do your flu and your pneumococcal vaccines. You're going to report the vaccine and the administration, and payment is based on reasonable cost through the cost report. And now that these vaccines are currently being distributed federally and provided to providers, there will be no reimbursement for the vaccine unless there is a separate agreement where the provider has paid for the vaccine and is not using the federally supplied. Skilled nursing facilities. So the Social Security Act requires SNFs to bill for certain services, including vaccine administration, even when SNFs rely on an outside vendor to perform the service. So therefore, in order to facilitate the efficient administration of COVID-19 vaccines to skilled nursing facility residents, CMS exercised enforcement discretion with respect to these provisions, as well as any associated references. Through the exercise of that discretion, CMS is going to allow Medicare-enrolled immunizers, including but not limited to pharmacies working within the United States, to bill directly and receive direct reimbursement from the Medicare program for vaccinating Medicare skilled nursing facility residents. Okay, so we've got some CMS vaccine billing tips. So Medicare fee-for-service is going to be handling the reimbursement for all of the managed care plans. So if you are billing out your COVID-19 vaccine and the patient is covered under a Medicare managed care plan, you want to send that to Medicare fee-for-service. And like I said, you could either send it roster billed, which you do, and I'm not sure if I mentioned this on that slide, but you do need to enroll as a provider in order to roster bill. The instructions are laid out on most of the Medicare MAC pages. So you just follow those steps, it's really easy. But once you have enrolled, you would then bill Medicare fee-for-service for the vaccines. There is no patient cost share for the vaccine. You're going to want to bill the administration only while these vaccines are federally supplied. And although it's not preferred, I did attend a webinar and we did ask this question. So if you don't have a drug, but you're billing an administration, a lot of times you're going to get edits in your EDI system. So we did ask them, hey, can we send that over on a penny line item charge, which is something that we commonly do for other services and have been doing for quite some time. Medicare did say that it's not preferred. However, you are not going to get an edit for this. It's not going to hit T-file. It is going to be pushed through if you do have that 1 cent vaccine charge on your claim. You're also not going to be receiving reimbursement, but that's just what's going to get it through your EDI system. So here's some more information on vaccine cost sharing. So this actually comes from the CDC, and it says that providers must administer the vaccine with no out-of-pocket cost to the recipient. No one can be denied receiving the vaccine based on their coverage status or network status. They may not charge an office visit or any other fee to the patient if the vaccine is the only service that was provided. They may not require additional medical services to receive a COVID-19 vaccine. Providers are able to seek appropriate reimbursement from a program or a plan that covers the vaccine administration fees, such as the vaccine recipient's private insurance company. And several of our top commercial payers do have pages specific to guidance for COVID vaccine billing. So I encourage you guys to go out there. United Healthcare has a really good page out there in addition to Premera and some of those Blue Shield plans. A lot of good information out there with specific instruction, but it is one of those things that you do want to check on a frequent basis because things do tend to change in this world pretty quickly when it comes to COVID-19 guidance. Medicare and Medicaid can be billed for vaccines. And then there's also the AzHHA COVID-19 uninsured program. And this is for non-insured vaccine recipients. There is a process, and the AzHHA website really lays that out nicely, where a provider can submit vaccine recipient information in order to receive payment for uninsured patients. So next we're going to get into, and I just want to show you this great resource if you haven't seen it already. The AMA put together an Appendix Q, which really lays out nicely all of the vaccines. It does include AstraZeneca, even though it has not received their emergency use authorization yet, but they have the AstraZeneca, your Pfizer, your Moderna, and then if I advance to our next slide here, you can see that we've also included the Janssen. So we do have this website linked in our resource page, but it really lays out very nice, very clean, a good way for you to see all the information in terms of the codes, the vaccine code, as well as the administration code, the names, your NDCs, 10th and 11th digit, and your dosing intervals there. So here is a resource page that I like to provide whenever we're talking about COVID things, because there is a lot of great information out there, but there's a lot of information. And so I find that this brings great value to folks that join our webinars so that they can just quickly click in to the information that we were providing. So in addition to links down in our sources for each one of our slides, we also have this resource page here in case you wanted to look up some of that information. My go-to source is always going to be a CMS, a CDC, depending on the topic that you're looking for, and we try to add some of that information in here. So. And then really, looks like we're going to end about halfway through. This was a real quick one. Let me check if we've got any questions in our chat, and I don't see anything yet. All right, so We've got a fantastic quote, and I've heard from some highly experienced presenters that the best way to end a presentation is with a quote. I'm a big fan of Michael Jordan, and one of his quotes here is, "Obstacles don't have to stop you. If you run into a wall, don't turn around and give up. Figure out how to climb it, to go through it, or work around it." And I think that that really speaks to really just the last 13 months, 14 months for some folks, that we've been dealing with this constant changes, and just trying to figure out a way that we can navigate these changes, and then make sure that we're being reimbursed for that as well. So on our last slide here, I've got a contact us in case you want to reach out to myself, Kelly Ryan, or Nikki Silva. We've got some contact information here. We're happy to help you answer any questions. And then also looking forward to some more training sessions. We're actually looking into doing maybe some more revenue cycle training that your end users, so maybe some appeal best practice and billing best practice. We're looking forward to doing more for you guys in the future. So feel free to contact us if you have any suggestions or any questions. And then Kelly will also be following up with a copy of our slide deck, as well as some additional information. So let me double check our chat, see if we have anything in here. And I apologize, we scheduled you for a full hour, but I just whipped right through this presentation. So I'm going to leave the chat open, leave the session open for just a couple of seconds in case folks are typing in a question. And then I think what we'll do is we'll go ahead and give you back the rest of your day.
Megan, hey, this is Kelly. One last thing to note is I will be sending out the slides to everyone. We will ask for your feedback, as Megan noted, on other possible topics, because we'd like to continue the educational component and outreach. But if you've got questions, once I send out that email, feel free to note anything you've got questions on or any other clarification you need in a response. But we appreciate you all joining, and have a great rest of your day. Happy St. Patty's Day. Enjoy.
Thank you.